Good afternoon and welcome again to this CME. We are grateful to have Professor Mammen Chandy with us. Our moderator today is Dr. Anjana Joel, consultant in medical oncology at CMC Vellore. So over to Dr. Anjana.
Okay. So thanks, ma'am. Thanks for that introduction. And again, thank you, sir, for being with us. So I did go through the list of participants, and it kind of comes across that we do have a lot of young and promising doctors who've joined us today. And well, Dr. Mammen doesn't need introduction formally to most of us. I will just maybe point out a few things. So sir's mostly a CMCite from the beginning, from the time of his undergrad. And he's probably been a trailblazer throughout from that time onwards. And he is one of the pioneers of the field of hematology and probably hemato-oncology in India. And he, of course, he is a recipient of many awards, including the Padma Shri recently. Now, what stands out about Sir is that I have had the privilege to have been taught by him as an undergraduate, and also to have had listened to a lot of his lectures when during my DM. And what I can promise you is that he holds your attention, and he's an excellent orator. He can sway you in whatever direction of any debate that he is on. And it's a pleasure to hear him. So thanks again, sir, to have accepted our invitation. Over to you, sir.
Thank you very much, Anjana. It's been my privilege to work at CMC and live at CMC. And when I look back on my life, I can say the best thing that has happened to me is CMC. And I will always cherish my work in CMC and the satisfaction it has brought me. So to get on with today's subject, my brief today is to share with you something about whether today we are actually in the era of genomic medicine. And I want to, in the next 45 minutes, try and convince you that it is in fact true, and that without genomics, it would be quite hard to practice modern day medicine. So I want to start with the guys who made all this possible. In 1953, Francis Crick and James Watson, working in the Cavendish laboratories in Cambridge, on 7th of March, announced to the world that they had found the secret of life. And you can see the model that they created in this basement. They never had any fancy sequencers or posh laboratories. So this was the basement of the Cavendish laboratories, where they put together with little sticks this double helix, which today we understand carries the letters and the language of our DNA, in essence, the essence of life. So it was, in fact, in a sense, true when Watson and Francis Crick announced to the world that they had found the secret of life. Now, this guy here is Francis Collins. He was the director of the National Human Genome Research Institute in the United States. And a working draft of the human genome sequence was announced in June of 2000. That's 20 years ago, right? And Francis Collins was amazing in that he said, we will put together all the letters of the alphabets which make up our DNA. And the human genome sequence was announced in June 2000. Now, this guy is called Craig Venter. Now, he's sometimes described as the bad boy of science because he jump-started a biological revolution. Because what took Francis Collins X number of hours to do, he did in X minus 10. So he was amazing the speed with which Craig Venter's lab at Celera Genomics could go ahead with the sequencing and contributing towards the human genome code. So Victor McCusick is considered as the grandfather of medical genetics, and he asserts that Craig Venter's contribution was spectacular, right? He was a bit of a maverick, so you see him in this coat. And I think a few years back, he announced that he had created life. That means he had put together DNA, which could make RNA and which could make a protein. And all of you know that all of our life processes essentially depend on DNA making RNA, making protein, and that's how we are alive. So he probably created some sort of microorganism which could, in fact, do this. So what do we have? We have an angel telling God that the human genome code has been unraveled. God is saying, damn hackers, now I have to change the password, right? So it looks as though mankind has been able to unravel the genetic code, and it has resulted in tremendous improvements in our understanding of disease and its treatment. Now, I want to pick a disease which is something in my field, but which actually is a paradigm for genomic medicine, and that is chronic myeloid leukemia. Am I loud enough? Can I be heard clearly? Yes? Okay. So this is the paradigm for genomic medicine, right? Now over here, you see Peter Nowell, who was the professor of pathology, and this is David Hungerford. He was just a technician in the laboratory. Now, in 1960, these two people announced the discovery of the Philadelphia chromosome. Now, if you look at this picture, if you look up here, you can see chromosome 22, and a tiny bit of the long arm of chromosome 22 is missing, where the arrow is, right? And that fact that this bit of chromosome 22 was missing, they thought was a deletion, that a bit of the long arm of chromosome 22 was deleted. Now, I think most of us would never have ever picked it up. Looking at that spread of chromosomes, I don't think I would have picked up that there's something wrong. So, which is why cytogenetics is probably one of the most difficult laboratory disciplines. You can't get people who are trained in looking at chromosomes, which is why today we have computers and artificial intelligence, which will help us analyze chromosomes. Now, this discovery of the fact that all of the patients with chronic myeloid leukemia that they study had this deletion of a bit of the long arm of chromosome 22 was published in Science in 1960. And this is the full length of the paper, one page. So if you want to tell something absolutely amazing, you don't need a lot of words, you don't need a lot of pages, you can do it in one page, right? And why was this so important? This was so important because for the first time, somebody had shown a consistent, non-random change in the chromosome in a human disease, right? So it was absolutely epoch-breaking that yes, a disease can have a genetic signature which can be picked up. And for that, we have to thank Peter Nowell and David Hungerford. But I think the major credit goes to the technician, who was David Hungerford, who actually saw and reported to his boss this change that he's seeing in all of the chromosomes in patients with chronic myeloid leukemia. So this great dame of cytogenetics, Janet Rowley, was the one who in fact showed that this is not a deletion of chromosome 22, but it is actually a reciprocal translocation where a bit of chromosome 9 is exchanged with a bit of chromosome 22. And according to Brian Drucker, her groundbreaking work on the identification of the translocation between chromosome 9 and 22 in patients with CML allowed the development of a life-saving drug, Gleevec, for this disease. Sadly, she died of ovarian cancer in the year 2017. So she is really a great lady, and her contribution to cytogenetics is immense. So as I told you, this is chromosome 9. This is the long arm of chromosome 9. And there's a little bit here called the ABL gene. This is named after a person called Abelson, who was the first one to describe an avian leukemia gene, which is called the Abelson gene. So the Abelson gene on chromosome 9 is translocated to chromosome 22, which is what you see here. So you have, and it's translocated near a region called the breakpoint cluster region. So you now have a new fusion gene, which consists of the BCR, which is fused to the ABL. So you have a new fusion gene. And this new fusion gene upregulates an enzyme called tyrosine kinase. So you can see here that when you have this translocation occurring between the BCR and the ABL, the tyrosine kinase is upregulated. This upregulation of the tyrosine kinase results in a huge number in the RAS MAP kinase pathway, the JAK-STAT pathway, the PI3 kinase pathway, and the net result of this is a number of genes are switched on. Joan Foss, cyclin D1, BCL2, CMYC, and this results in the uncontrolled proliferation of the myeloid series, which is the hallmark of chronic myeloid leukemia. So it's amazing that this little translocation between the BCR gene and the ABL gene switches on a whole series of molecular events, which ultimately results in proliferation and causes the disease that we know of as CML. Now, how has this impacted the way we look at CML? It has altered the way we diagnose CML. Secondly, it has altered the way we monitor the disease. And thirdly, it has been a paradigm shift in the way we treat. Today, when a patient comes to me with a white cell count of 150,000, and which is left shifted with a few basophils, I don't do a bone marrow. I send off a peripheral blood sample to the cytogenetics lab for a fluorescence in situ hybridization. So we have a green probe for chromosome 9, and we have a red probe for chromosome 22, the BCR gene, and this is for the ABL gene. And can you see what has happened here? The green and the red have fused together, giving us a signal which is yellow, which tells us conclusively that there has been a translocation of genetic material from chromosome 9 to chromosome 22, resulting in a BCR ABL new gene. And you can see that in this particular cell, there are 2 copies of the BCR ABL translocation. So no bone marrow, not required, just a FISH test. And with a FISH test, I have a conclusive diagnosis that this patient has got chronic myeloid leukemia. What next? I start treatment. And when I start treatment, I need to monitor what is happening to the translocation in terms of the number of mRNA molecules that this translocation is producing. And I do that with a nested real-time PCR, right? And with this, we can actually say that there are so many copies of the BCR ABL gene as opposed to the ABL, which is a housekeeping gene. And this is an example of how with RT-PCR, we can actually work backwards down the slope of the amplification and say, yes, there are so many copies. That is the precision which genomics has allowed us to do today. So when we make the diagnosis, we start on treatment, and I usually repeat the RT-PCR at the end of 3 months. And if the transcript level is less than 10%, then I know that my first generation and work for the next 10, 15 years. So it's amazing how genomics has altered the way we diagnose and monitor CML. Now, this is an improvement on the technology. It's called ddPCR, where we take a droplet, split it up into millions of tiny droplets so that one droplet has one copy of the gene. And we then amplify using this type of equipment. This is called the rain dance, which makes 1 million copies from a single drop. And this is what we have in our lab, which is the Biorad ddPCR equipment. And this allows us to do an RQ-PCR with greater precision. Today, with this type of technology, we can pick up the mutations in the DNA which is circulating in your blood and say, yes, you have this particular mutation which is sensitive to this particular drug. If you have lung cancer, say, we can actually estimate the mutation or document the mutation by doing a ddPCR from a blood sample without having to go and biopsy the tissue. Now, how were we treating CML, right? In the early days, we were using a drug called busulfan, and that was the only treatment we had when I was an MD in training. And I still remember Ms. Varki, who was the superintendent of our canteen, the YWCA canteen. She had CML, and when she was retiring, she said, Dr. Mammen told me I will live only for 3 years. It is now 6 years and I'm still alive, right? So we shouldn't make any projections. But she, in fact, didn't have anything more than busulfan, right? And busulfan is not a nice drug. You get pigmented, you don't look good, your quality of life is not great. So then came allogeneic bone marrow transplantation. That became a cure for CML, which we never believed was possible. And this is Donald Thomas, who is receiving in 1990 the Nobel Prize in Medicine. He received it along with Marrow, who worked on renal transplantation. Nowadays, only biochemists get Nobel Prizes because it's rare for a clinician to get a Nobel Prize. But this is Donald Thomas, who pioneered bone marrow transplantation and produced this type of curve. So if you have a HLA identical sibling as a donor, you have a 60% chance of being alive, well, and cured of your disease. And this is data from transplants done for CML in approximately 6,000 patients with CML between the period 1991 to 1999. We now don't do a transplant for a newly diagnosed patient with chronic myeloid leukemia. So this was the cover of Time magazine, and you can see this is the new ammunition in the war against cancer. And these are the magic bullets, right? And this was referring to Glivec, which is the drug which has transformed the way we treat CML. And the man who brought it to the clinic is Brian Drucker, who in fact did the initial studies on patients with chronic myeloid leukemia. How does this drug act? Now, if you look, this is the BCR-ABL. And you can see this is the gene. And you can see there's a little pocket here where the green fellow, which is ATP, comes and binds. Now, when ATP binds to the BCR, it acts as a phosphorylator. So what it does is this is the substrate which comes and attaches to BCR-ABL, and you can see this little red ball is tyrosine, and the yellow is, you can see that this is the ATP. And what happens is that you get the phosphate being added on to the tyrosine residue of the substrate, right? So you can see that this now becomes activated merely by the addition of a phosphate. So the yellow dots here are the phosphate, and this is a tyrosine residue on the substrate. So the substrate has now been phosphorylated, and when it is phosphorylated, it becomes activated. So when you have this mutation in your BCR-ABL, the tyrosine kinase is upregulated, and it constitutively goes on phosphorylating the substrate, and that is what results in this whole sequence of events. So we have this wonder drug, which comes and snugly gets into this groove where ATP would have bound. And because imatinib is sitting there, the ATP cannot bind. And because it cannot bind, there is no phosphorylation. So you can see that the tyrosine residue doesn't have the yellow dot, which is phosphate, and it is inactive. So this molecule is amazing. Just goes into this groove, blocks the ATP, and makes it non-functional so that the substrate is not auto-phosphorylated. So one of the things which has always amazed me is that so much of life's processes are dependent on the addition or removal of a phosphate. So you have phosphatases and you have phosphorylases, and these are what make the chemistry of life just by adding a phosphate group or removing a phosphate group. And that brings me to this guy who is Yallapragada Subbarao. I think he should have got the Nobel Prize twice over, right? This is the home in Andhra Pradesh from which he came. This is his child bride over here, and he migrated to the US. Now, can you imagine Yallapragada Subbarao's contributions, right? He is the first one to develop a method with Professor Fiske for measuring phosphate in tissues, right? Even today, it's called the Fiske-Subbarao method for measuring phosphate in tissues. Now, this great man actually is the one who, with St. Georgi, showed that, in fact, metabolism is dependent on ATP. That discovery itself should have given him the Nobel Prize, right? He is the one who synthesized folic acid. Can you imagine that? Before that, a chap called Snellen in the US took 2 tons of spinach and made 1 milligram of folic acid. Yallapragada, working in the Lederle laboratories, was the person who actually synthesized folic acid. And because of that discovery, the first anti-cancer drug, Amenoctrine, was developed in, I think it's Harvard or Yale, with Subbarao's help. He discovered heterozyme, and his discovery of synthesis of folic acid made it so cheap that we could give it to every pregnant woman and prevent the development of spina bifida and problems related to folate deficiency in pregnancy. An amazing Indian who 90% of medical students know nothing about, right? So it's amazing. So if you look at what happens when you start imatinib, right? You are able to control the disease, and this is a survival curve showing that at the end of more than 5 years, the IRIS study goes on to 15 years now, that on 400 milligrams of imatinib, about 85% of patients are living normal lives with chronic myeloid leukemia. We don't take them up for transplant. But disease is always smarter than our best efforts. So the CML cell undergoes a mutation in the ATP binding groove, which you can see here. These are some of the mutations. They're called P-loop mutations. And these mutations prevent imatinib from coming into the groove and switching off the BCR-ABL. But does science stop? No. We now, by molecular genetics, can actually diagnose the mutation. And the worst of these mutations is a mutation known as the T315I mutation. And this mutation will make you resistant to all the first and second generation tyrosine kinase inhibitors that are available. So can we diagnose? This is a technology called the nanostring, which helps us to quickly document the mutation. And scientists are constantly working on molecules which will continue to work even if there is a mutation. So we have a drug called dasatinib. We have another called nilotinib, bosutinib, and this drug called ponatinib is a drug which can actually overcome the T315I mutation. So science moves on, and this is the latest edition that we don't want to go anywhere near where there is mutation in the ATP binding. And this is a myristylated N-terminal, which goes and locks in over here and renders the BCR-ABL inactive. Now, when you have a mutation, that myristoyl terminal is removed. And you have a drug which is called asciminib, which can go in and snugly fit into that and make the molecule inactive. So as the disease discovers ways to avoid our targeted molecules, so science goes on innovating and developing new therapies. So what has genomics done for us for chronic myeloid leukemia? What it has done, it has changed from carpet bombing to sniper shooting. So instead of whacking the person with a transplant, causing GVH and other things, we now are sniper shooting with a tyrosine kinase inhibitor. So targets, we do that by morphology. We do that by looking at the proteins which are present on the surface. We do that by looking at the chromosomes and then sequencing the DNA and finding the mutations which are responsible for the altered biology in different cancers. This is a sequencer from Iron Torrent, and this is what the MedGenome lab in Bangalore looks like, where they have high throughput sequencing, which can do millions of base pairs in a run and help you to find and identify. So the technology now is next-gen sequencing, where we can, using these technologies, quickly identify the mutation which is responsible for the disease. Now, this was a disease which we knew for many, many years, hairy cell leukemia, where the cells have these projections on them which look like hairs. And we never ever thought of trying to find out what is the cause of this disease. Till recently, Brunangelo Fallini from Italy, in fact, found out that there is a mutation. It's called the Braf gene, and there's a mutation where valine is changed in position 600 in the molecule, and this change results in an upregulation of various kinases. A drug was developed to block BRAF, and this drug was called vemurafenib, and it was slated to be used for melanoma, but it didn't work so well for melanoma. Then they realized that, in fact, vemurafenib can be used for hairy cell leukemia. So it's one of the second or third line therapies which we line up for hairy cell leukemia. This is another disease called anaplastic large cell lymphoma, where there is a new kinase, which is the ALK kinase, and we have now new therapies for this disease. I have a medical student who is now only on one drug, which has kept his anaplastic large cell lymphoma at bay. Now, we don't always strike gold. For myeloid leukemia, for many, many years, despite all the sequencing, we never had any therapy. But suddenly, in the last 2-3 years, from the boulevard of broken dreams, we now are in the highway of new approvals. And today, you can see that so many new therapies, 9 new therapies have been approved in 2018 for acute myeloid leukemia, and all because of an understanding of the molecular defect in this particular cancer. So the drugs of the future are not going to come by empiric testing of millions of molecules. They're going to come by understanding genetic pathways in different diseases and cancer, and designing molecules which will go and block off that particular target. Now, if you think it's easy, I would like to tell you no. This is the EGFR gene, the epidermal growth factor. And these are all the downstream pathways which are activated when EGFR is activated. So if you think you've got something which is going to block this, the tumor will take another pathway down, which is why for solid tumors, we have not seen the huge success that we have seen in hematologic malignancies, but I'm sure that there will be breakthroughs. So will the medicine of the future, instead of this young lady with empathy and kindness looking at the patient, be a computer which spews out your diagnosis and tells you what to do? I hope not, right? But we certainly are in the era of molecular medicine, where there is precision in diagnosis at the molecular level. We can accurately monitor the disease. We can risk stratify based on the gene expression profile. We have new targeted therapies. And ultimately, I hope we will have gene therapy. However, we must be careful when we apply genomics to routine clinical practice, right? We know that one size does not fit all. So when you are trying to treat a patient with DVT, the drug we used to use was warfarin, and we know that there are two key enzymes, vitamin K reductase and vitamin K epoxide reductase. And we know that you can monitor warfarin by doing a PT at your home with a drop of blood, and that doesn't cost much. But there was a recommendation that everybody who started on warfarin must have a VKRC genotype done. And if you were sensitive, the starting dose was lower with the AA genotype. If you were resistant with the GG genotype, then you would require a higher dose, and the average was the AG genotype. Now, a lot of people were put on warfarin. So if you were to genetically test all of them, it would cost approximately $1 billion. And that's not money available in most healthcare systems. So in fact, genomics is not properly applied when we say everybody must have a VQRC gene testing, right? We'd rather do a simple PT because we know that drug effect is dependent on a huge number of factors apart from the genetic polymorphism. And therefore, it is not cost effective to do a genetic study before starting warfarin. A few words about gene therapy. Now, all this understanding of molecular genetics has led to us being able to provide the defective gene being replaced. We can then package the defective gene into a viral vector and insert it into the cell of interest. We can also now edit the gene by having a guide RNA which will go to exactly that spot and edit it. And gene editing can be used for sickle cell and thalassemia. And I'll show you an example of that. And one day, maybe we can even inject the editing tool and it'll go and correct if we direct it to the correct cell of interest. That's called in vivo gene therapy. Now here what we do for thalassemia is we harvest stem cells from the patient, we insert the gene of interest, then return it. So we as bone marrow transplant people are going to have work because harvesting the stem cells, destroying the disease stem cell, and putting back the gene therapy cell, the gene corrected cell back is still going to be within the purview of those who understand hematopoietic stem cell transplantation, at least for genetic disease of the hematopoietic stem cell. And this is the correction with a lentiglobin vector. And these are the two people who got the Nobel in chemistry in 2020, Emmanuel Charpentier and Elizabeth Doudna, for their work on gene editing. And they introduced the CRISPR-Cas9 technology for editing genes, right? And this is another example where there's a gene called the BCL11A. It's an epistatic suppressor of fetal hemoglobin. And if you can go and hit BCL11A and stop it from functioning, you can increase the amount of gamma globulin and correct the defect both in thalassemia and in sickle cell disease. And this is disrupting the BCL11A and pushing up fetal hemoglobin. And it's now, clinical studies are done where you can actually reverse the phenotype. I just want to close with one example of how genomics has transformed medicine, right? We had a 4-year-old male child, first born to non-consanguineous parents, skin lesions, infection, thrombocytopenia, and small platelets. This is not him, but it's a Western child with this disease called Wiskott-Aldrich syndrome. Now, this is a genetic defect in a protein called the WASP protein, which is involved in cytoskeleton, and when this is disrupted, you have immune deficiency and thrombocytopenia. So we started in Vellore to try and document the mutations in our own cohort of patients, and this resulted in the presentation at ASH of a series of mutations which we had seen in our patients. Now you might say, so what? So you have found the mutation, fantastic. How does it help anybody? So what we did was we diagnosed the mutation in him, and we couldn't do much for him. The poor boy was skin and bone, bleeding, repeated admissions with infection. And then mom came to us about 4 or 5 years later with this. Now, any of you who are obstetricians in the audience will be able to tell me that this is a twin pregnancy, right? So what did we do? We sent the lady to our reproductive medicine unit, and we discussed with the family that if the babies are affected, we will have to do an abortion. So they went, and we got a bit of DNA from this placenta, twin A and twin B. So a bit of DNA from twin B. And we found that twin A was a male and affected. And we found that twin B was a female and unaffected. This is a sex-linked recessive disorder, so it's mostly a disease of males. So we have to inject potassium chloride into the heart of the affected male twin, and that will blight that fetus, and the pregnancy 98% of the time can continue to term. So father was a Roman Catholic, and he said, sir, how can you do such a thing? So I said, I did the genetic testing only because you agreed to an abortion. Now you're saying you won't have an abortion. So what a great hematologist I am. I didn't even think. So he said, sir, can you not check whether the two are matching and you can collect and do a transplant with the unaffected female? So suggestion coming from the father. And that's exactly what we did, right? We knew that the female was unaffected. So at the time of delivery in Vellore, Biju collected the stem cells from the unaffected female. We froze them and kept them, right? We then did HLA typing and proved that both were HLA identical. They were not identical twins, but they were HLA matched. And the HLA testing is done by molecular technology now, not by the old methods. So what did we do? This was the male twin. We took the harvested stem cells from the female, kept them frozen, and when the baby was 6 months old, I think that's when he came, and we did a cord blood transplant using the stem cells of the unaffected female twin. And this is the little fellow when he was ready for discharge. Now the father somehow didn't give up. He said, I have to find a solution. And therefore an uncle was found who was HLA matched with him, who was the elder boy. And this is the fellow, the little twin, when he was getting discharged after his transplant. And this is a picture which is very precious. This is him who had a transplant from an uncle. Now, you know, to get a full HLA match from an uncle is not easy, right? So transplant transformed his life. He was thin and miserable, coming in and out of hospital all the time. And this is the little girl who donated her cord blood stem cells. And this is the little boy who you saw as a baby in the previous slide. So what has genomic medicine done? It has pushed us into the new millennium, which is a remarkable time for medicine, where the potential for bettering human health is unequaled in history. The ongoing revolution in biomedical science of unprecedented magnitude is accelerating dramatically and promises almost unlimited opportunity for the betterment of humankind. These words are from David Nathan, who is a pediatric hematologist, and he is the editor of the Nelson's textbook of pediatrics. So I hope I have convinced you that, in fact, we are today in the era of genomic medicine, where diagnosis, monitoring, and treatment of disease, which hitherto was not possible, is certainly going to be possible. The only rider is that most of these treatments are expensive, and we hope that someday the costs will dramatically come down. Thank you very much.
That great lecture, as always. We do have a few questions which have been. Am I audible, sir?
Posted, yes. Yes, you are
Yes.
audible.
Yeah. Shall we take those first, and of course we can go on to the rest of the questions later.
Okay.
Mm-hmm. So I
You
think
will read them out?
Sir?
They've been sent to me. So would you like me to share the screen, or I'll just read them out?
Oh, I think if you
can
have it
read
on
them
your
out.
computer, you can share and you can read them out too. Either way works, if it's okay with you.
Okay. The first question which has come to me is, how have we utilized genomics for clinical guidance with respect to challenges like COVID? Prediction of COVID, severity or response to treatment. What is the framework globally for these challenges? Now, I'm not a COVID expert. Almost every day on the TV, we find people coming and posing as COVID experts, from surgeons to others. But I won't claim to be a COVID expert. But actually, it's quite apparent that it is genomics or molecular genetics which is helping us with regard to providing a vaccine for this disease. And we know that the Pfizer BioNTech vaccine is actually an RNA vaccine. And it is all of this genomic technology which has allowed us to rapidly produce vaccines, whether with proteins or with RNA, for the epidemic. And we also know that there is some link between the angiotensin converting enzyme and the predilection for the virus to enter the cell. So apart from that, I really don't know much more to tell you how genomics is altering COVID and its management. What are the cost implications? Now, initially, they predicted that it would cost more than $100,000 to completely sequence the human genome. We think today it's possible to do it at about 2,000 US dollars, but that still is a lot of money, right? But you can get today a targeted next-gen sequencing to diagnose a rare genetic disorder at a cost of about 20,000 rupees. So targeted next-gen sequencing is in the region of 20,000. That is where you don't know what the mutation is. Now, where you know what the mutation is and you want to track the mutation, like in CML, like I showed you, it costs about 5,000. And I generally do an RQ-PCR at diagnosis at 3 months, once in 6 months for people who can afford, once a year for those who cannot afford too much, and the cost is about 5,000. So the cost of most genomic techniques are rapidly coming down, and technology and science are moving to make these things applicable to routine clinical situations. How to apply in the pandemic situation, I've already given you the example. Unfortunately, I don't know more than that about COVID. current and future applications of genomic medicine in primary care to tertiary care centers. Now, if you ask me, can I practice modern hematology today without genomics? The answer is no, right? And what I feel really proud about in CMC Vellore is that we decided to go down the genomic pathway a long, long time ago. Alok and I went to Indian Institute of Science. We went to a lab and am I back on?
Mm-hmm. Yes.
Okay. So Alok and I went to a laboratory in Bangalore and we wanted to find out how we could go about setting up a molecular lab. The guy gave us a book and said, you can sit outside and read. That was the level of cooperation we got from that particular lab. I'm not saying everybody there is like that. Okay. I was giving a talk in France and there was a person in the audience who was an Indian. He was a director of an INSERM laboratory. And he came up to me after the talk and he said, Dr. Chandy, can I help you in any way? And that collaboration actually resulted in our foray into molecular genetics. We started doing DNA fingerprinting for bone marrow transplantation to document the presence of the host in the recipient. And that was technology which we got from France, from a forensic lab, right? You don't have to do any of that. The people who joined our department, the first two PhDs, were Dr. R.V. Shaji and Dr. Pungarili. Pungarili is now an expert on pharmacogenomics, and she trained in the best labs she went and picked up the technology from Eileen Jacques in Paris and subsequently in St. Jude's in the US. And Shaji today is probably the most respected molecular geneticist in the area of thalassemia. We are now offering in Vellore diagnosis for a whole range of blood disorders. Indian couple in Japan, where the mother was a carrier for hemophilia, had to come from Japan to India because they're not doing antenatal diagnosis for hemophilia in Japan because they don't believe you should abort a hemophilic baby. So that's the sort of breadth of what we are now able to offer in Vellore because we have a really good group. It's not just the machines, it's the individuals who have trained to understand the science of genetics. Next question is application in primary care. Okay. Now, point of care testing for genomics. Shaji is actually doing some for thalassemia, where we think that with a paper strip, you could diagnose the mutation in thalassemia. What will be the scope of gene therapy startups in upcoming years in India, right? I think tremendous scope. The sort of therapies which are gene-based, like CAR T-cell therapies, are all dependent on genetic technology. So Alok in the Stem Cell Center is in fact hoping to be the first to do some gene therapy for blood diseases in India. And I think the scope is tremendous. See, a gene therapy is going to cost approximately $1 million in the US. Surely we can do it for much lower cost. Applications of genomics in nutrition and diet planning. I'm afraid that's beyond the scope of my knowledge. So Anjana, that covers all the the topics that have come to me already. And for some reason, my video has gone off. Okay.
Okay, just a few other questions or maybe clarifications which I thought could be relevant. Now, a lot of people have sort of asked whether does this approach of genomics, does it only benefit, say, a small group of patients? Does it only benefit a specific or rare subgroup of diseases? Is it really worth it it's definitely worth it at an individual level. Is it worth it at a level of a population, especially in a country like India? I think that it's probably a slight repetition of the primary versus tertiary center, the cost concern.
Okay, if I can answer that question with thalassemia as an example. Okay, India is supposed to have more than 20 million people who carry the gene for thalassemia. We believe that 10,000 babies are born each year with thalassemia. And with the application of good public health, with screening for this disease by simple techniques like HPLC, and offering antenatal diagnosis by molecular DNA techniques, we can actually get rid of this disease. So at the public health level, to me, there is no doubt about the fact that genomics are applicable, can transform lives. And you can imagine having a child who has to be transfused every month, because who can afford gene therapy now? Who can afford getting reliable transfusion? It's a nightmare for a couple to keep coming and getting their child transfused. Genomics is the answer at a primary level. So if every obstetrician did an MCV, if it was low, did a HPLC, confirmed that mom is a carrier at the first visit before 20 weeks of gestation, sends for antenatal diagnosis. And there are more centers which can offer an accurate genomic diagnosis without making a mistake because of maternal contamination. We can change the face of this disease in this country. Now look at microbiology. Tomorrow's microbiology is going to be genomics. We are going to diagnose resistant gram-negative bacilli by genomic technologies, right? That's the future. So without any doubt, COVID testing, genomics, costs come down to 800 rupees per test. They were ripping us off when they charged so much for the kits, but the government stepped in and said, no, you can't charge more than 800. So would we have been able to diagnose COVID without genomics? The answer is no. Every week I do a CMV PCR to pick up cytomegalovirus in my transplant patients. So if you ask me, there is no field of medicine which has not been touched by genomic technologies.
Okay. Another question from, I would say, mostly like a therapeutic or maybe more relevant for us, especially as far as we deal with solid tumors, is that is it worthwhile doing some of these NGS without access to appropriate treatment? That is one question some of our colleagues had raised. Should you really do it? Because in the West, you have access to clinical trials. You can get onto trials for newer medicines, for newer targets. Is it really worth it? What are your responses to that, sir?
No, I fully agree with you. In this country, when we practice medicine where there are limited resources, I think we have to use genomic technologies very, very carefully and appropriately. For instance, CML. If I don't have access to second generation TKIs because of the cost, what is the point in doing a mutation analysis for CML when he's not responding? It's a waste of time and money, right? So once I've made the diagnosis, I then track only with a CBC, nothing else, because this particular individual cannot afford anything else other than imatinib for 2,000 rupees. So I'm not going to keep doing mutation testing and all the rest of it, right? So we have to accept the limitations of the resources available and respect that. We have a patient with non-small cell cancer with mets in the brain. If they don't have money, what's the point in doing a ddPCR and finding out that there is a mutation in the EGF, and that I have a drug called osimertinib, which can cross the blood-brain barrier and actually tackle the secondaries in the brain and maybe give a year of life. But a year of life at what cost? So a chap who's earning 5,000 rupees a month, you can't say a year of life at so many thousands of rupees is a difference. So that is the question we have to struggle with. But if you look at it, should we do bone marrow transplant in India? The answer is yes, because we have the technology available. And if I don't have genomics, if I cannot do an accurate HLA typing without genomics, I cannot do chimerism analysis without genomics. So it's essential. And what cost $250,000 to $500,000 in the US, we are able to do for 8 to 12 lakhs in India. So I don't think we should ever be negative about it. And I think that as money becomes available, we will be able to resource doing this. And in fact, this is much less expensive than doing it the other way, where you don't know what you're dealing with.
Okay. The other question which we kind of had is that again this is mostly do we have like for example in solid tumors, I think this is mostly extrapolated from solid tumors, a lot of data supporting this sort of a genomic approach is mostly in the metastatic setting. And why don't we have that similar data in the adjuvant setting? We may have some data, say in breast cancer, we may have a few in some of the GI cancers, like say stage 2 colon cancer and MSI. But why is that lacking in the solid tumor setting, say in the localized adjuvant setting vis-a-vis the metastatic setting?
I'm not really a solid tumor person, but to tell you the truth, I think in the next 10 years, what has happened to hematology is going to happen in the solid tumor space. But it's going to be much tougher and much more difficult. But I think it's going to happen. And that soon we will have a catalog of driver mutations. We will have a catalog of small molecules which are applicable to different mutations. And that's going to happen even in the solid tumor space. It's going to take time. And initially it's going to be expensive. But I think ultimately costs will come down. And you also, like me, are going to feel that without those tools, you cannot really practice good quality medicine, even for the poor. You know, this idea that genomic medicine is only for the rich is not correct. In fact, it means a lot more when you can say, okay, this disease is P53 mutated. I do not have the ability to use venetoclax or this drug. Therefore, I think it's better that you go home on this medicine. You don't waste precious little money giving therapies which you know are not going to work, right? So even for the poor person, it is, if you can confidently say, because after all, most human beings want to know that they have done the best possible for their loved one. And they feel guilty if they couldn't. So if you can confidently say, hey, we don't have a drug right now which can be used for this P53 mutated tumor, and therefore it's better that we stop them and move into palliative care. It gives a lot of consolation to the family. So yes, it will happen. Till it happens, we have to be careful how we use these technologies. And the sad thing is the greed which drives the intellectual property right? Imatinib which cost 2,000 rupees. Can you imagine how many billions of dollars shareholders were getting from this drug for 30 years, right? Human greed. Today, there is a science where you have got a drug called emicizumab, which can transform the life of a child with hemophilia. One subcutaneous injection once a week cost $400,000. But costs are coming down. And why should it cost so much? Not because it costs that much to produce it. It's because our world is mad and people want to make millions of dollars with a share market and a capitalism which has actually gone bad. So if our world was a bit sensible, Manucci used to say, we produce 1 kilogram of factor VIII, we can meet the needs of the world. But will the world do it? No. Right? That's the sad thing of our world today.
Okay. I don't see any other questions in the chat box, so I think I'll hand it over to Dr. Reena. So thanks again, sir.
Thank you, Anjana. Thank you.
Thanks, sir.
So thank you for a fascinating talk, from the discovery of DNA to your own discoveries in Vellore, the impact at the individual and the global level,